This is Beth Rosenthal. I'm with the Academic Collaborative for Integrative Health, also known as the Collaborative, and I am the Director of Working Groups. And this is my great pleasure. I'm actually really excited to be able to speak with you all today about this study that I've been involved in with my co-investigators, Anthony Lisi and Hannah Gravrand, and we'll each be talking with you today, and as I said before, we've left plenty of time at the end for your questions and answers and comments. So we're talking today about a study that we conducted about interprofessional collaboration among complementary and integrative health providers who are in private practice and community health centers. And what I'd like to do now is before we move on to the overview, invite my co-investigators to briefly introduce themselves, and they will be speaking during the presentation. So first I'd like to start with Anthony Lisi. Can you just say a word about yourself?
Yes, thank you, Beth. I'm the Director for Chiropractic Services for the Department of Veterans Affairs of the VA health system. And I am an associate research scientist at the Yale Center for Medical Informatics, and I've focused on assessing clinical care and the implementation of CIH services, mainly chiropractic, but also other services in medical systems. And I'm really glad to be here.
All right, my name is Hannah Gravrand. I'm a chiropractor also working in the Veterans Affairs hospital. I'm out here in Reno, Nevada. I originally started my journey working on this study when I was a resident working under Dr. Lisi, so it's been a couple years now.
Thank you. Thank you. Work began on this study in 2015, and now you're going to get a little overview, and then we'll end up with the findings and results, and that's when we'll open up for discussion. So here's what our time together will look like today. We'll have about 5 minutes, and we're just completing that now with our welcome and overview. And then Hannah will tell us a little bit of background and purpose of the study and continue on to talk about method and subjects. And then Hannah and Tony together will begin the discussion about findings and the discussion portion. And then Tony and I will end up with conclusions and acknowledgments. That'll be our wrap up, and then we'll open up for Q&A. And we're doing great on time, so thanks everybody for being on time. And Hannah, I'll turn it over to you now.
All right, thank you, Beth. So first we want to touch on the background of our study. The current healthcare environment is increasingly placing emphasis on interprofessional collaboration. And many previous authors have shown that interprofessional collaboration can improve healthcare processes and outcomes. And we know that patients are best served when healthcare providers understand and respect each other's professions and are able to work well together. And specifically, interprofessional collaboration may be of particular importance to complementary and integrative health providers, CIH providers, who have historically practiced in silos or in relative isolation from each other, and also isolation from mainstream medicine. So there's a growing trend that complementary and integrative health providers are included or being included in mainstream medical systems and facilities, but the vast majority of CIH providers still are delivering care in private practice settings. Now, the extent to which these providers are collaborating with each other and with other providers is not really known. So that's sort of why we decided to pursue this study. So the next slide. So the purpose of this paper really was to investigate what are the aspects of interprofessional collaboration that is occurring amongst complementary and integrative health providers. So we focused on a sample of providers from 5 licensed CIH disciplines. That included acupuncture and oriental medicine, chiropractic, direct entry midwifery, massage therapy, and then also naturopathic medicine. And this includes providers in both, again, a private practice setting and those practicing in community healthcare centers. Specifically, we focused on community healthcare centers which provide care to the medically underserved communities, or MUCs. All right, next slide. So the method followed a qualitative healthcare service study, and we used semi-structured interviews and a purposive sampling approach. So this study assessed these two CIH provider populations, as I just mentioned. The first group was the clinicians in private practice settings, and the second were the clinicians in community healthcare settings. Again, specifically in the medically underserved communities. And for both of these groups, we sought to, first we wanted to document and characterize what the current state of interprofessional collaboration is, including, what are the facilitators to interprofessional collaboration, and what are the obstacles that we found. And second, we wanted to identify what could be done to strengthen and expand the amount of quality and of interprofessional collaboration amongst these providers, and also the structures and processes. How can we strengthen and expand the structures and processes of CIH providers to contribute to community healthcare? So for the purposes of our study, we wanted to operationalize the concept of interprofessional collaboration, and we used model competencies that were proposed by various professional entities in mainstream medical disciplines. But then we also used secondary operational frameworks that we developed to be more specific to CIH disciplines, the complementary and integrative health disciplines. And the data analysis followed a directed content analysis approach. All right, so next slide. There we go. So in this, on this slide, you'll see a chart that included, the subjects for our study. In the first column, you'll see the private practice, 2 to 3 providers per discipline, a total of 12. And then in the second column, you'll see actually a third at the bottom, you'll see other CHC. So 3 of the 14 CHC providers were classified as other because they provide care to the underserved community health centers, but they're not single discipline CIH providers. So one of them was dual degree in acupuncture and oriental medicine and also massage therapy. Another one was a nutritionist and herbalist. And the last one was actually a medical doctor. All right, so next slide. Okay, so to start talking about findings, on this slide, it touches upon the overarching themes that we found amongst all of the subjects. So one thing we found is that most subjects had little to no exposure to interprofessional education, so IPE is interprofessional education, during their training. But at the same time, they emphasized the importance of interprofessional education for students in their professions, their current or future students, seeing this of value. Another thing we found is that there were differences in the way that referrals were approached outside of the clinic, different approaches to that. Another thing is that most subjects reported significant importance in having or finding time to communicate with other providers in this context of interprofessional collaboration. And most subjects reported that interprofessional collaboration was a strong positive or has a strong positive impact on patient care and on professional satisfaction. So at this point, I will hand it over to Tony Lisi to continue the findings.
Great, thanks. Pardon me. So we also we tried to summarize what the participants experienced in terms of the results of this study. So what they told us actually has happened in their during the time of their employment or their participation in these various settings. But then we also, in addition to asking them what has happened, we asked what they thought should happen, or what were their suggestions for improvements that can be shared in terms of preparing future providers in terms of training, in schools or other types of postgraduate training, as well as just information for systems that are seeking to bring in different providers. And I'll highlight just a few. This is a busy slide, and so we have some of the slides are a little more detailed, and for folks who are interested could see the publication. But a very common theme was the idea, or the suggestion of educating other providers about the given CIH discipline. And respondents were involved in doing that themselves. Many times they were just bootstrapping that. They came up with their own presentations or talks or just off the cuff type of conversations that they had to have with other providers, and felt that they would have been helped by having some more resources that they can use to educate the traditional providers about their respective disciplines. So this gives thought for professional organizations or schools in the CIH world to think, and then also specifically about schools, the idea of educating students that, as Hannah mentioned before, most of the participants, pardon me, stated that they did not receive any training in how to interact, how to integrate during their clinical training, but that it would be of big value and that would really have a positive impact on their practice and patient care. And by that we mean sort of practice or professional activities, professional satisfaction, the types of activities that involve perhaps serving on committees or being involved in scholarly activities or research or even academic or training activities at the facility. So the sort of the hallmarks of a professional healthcare provider outside of patient care, but then specifically with patient care, how it would make it easier for them to facilitate care with the other providers with their patients, ultimately getting better patient outcomes and better patient experience because they were part of the team. Pardon me. That largely came through in all of the permutations, but we specifically note it in terms of the private practice folks here. And you'll see there's a lot of similarities if you just read the bullet points, which I won't read all of them, but the one thing I'd like to highlight is that many providers, and this is from this work as well as others, to just put in some context, the first, a common thought among CIH providers is that how important it is to educate the mainstream providers about their given discipline. But what's particularly relevant is the reverse that came through in this study, that folks realize that it's important to educate the future providers in the CIH disciplines about what it means to integrate and about the other providers that one will encounter in an integrated setting. Next slide, please, Beth. And some general themes that came through about the value of integration is that it enables a given CIH provider to provide a broader experience for a given patient, because as we all know, the various disciplines all have many successes, but nothing works across the board for everyone, so it's valuable to have that team approach to care. And that the ability for folks to excel in their own given discipline. In VA, we have a mantra that says something like, we want our providers to be functioning at the peak of their training and competence, so that the ability for the CIH providers to integrate in these various settings is enhanced when they feel that they're able to perform at the top of their training and to be able to bring that to the table with the other providers. Now this next point is more of a self-serving one, about for an individual provider feeling gratification in and maybe a higher degree of professional respect and professional recognition, and also in terms of compensation, that many folks felt that the collaborative environment allowed them to have access to more patients. So from a provider-centric perspective, we did get these themes of people reporting that they felt that it was of value to them as individuals beyond the more altruistic patient care and benefits to society. And then in general, I mean, this last comment tries to illustrate a theme that came through from many of the participants, that they get better patient care outcomes and at the same time feeling like it's enjoyable, or it's a rewarding environment. So that sort of double-sided coin of being able to do a better job for patients, but also feeling rewarded and feeling good about being part of a team. So they perceive that to be of value. Pardon me. Next slide, please. And again, some of these start to dive deeper into the specific themes, but I'll highlight a few that the self-reflective, or what sometimes is called a learning system, that by these providers, when they're in a larger environment, are actually forced to think outside the box more and to have a broader perspective and question what they do, look at their own outcomes, look at their own performance measures, which often doesn't happen in a single provider, private practice, or even a small group of CIH professionals. That the patients, although we didn't talk to patients, our respondents told us that their patients reported to them a greater degree of satisfaction because of this perception of team-based care, and that in consequence, that the patients often felt well cared for, even if a given provider didn't necessarily have a home run clinical encounter with that patient, but that they still felt value in what the CIH provider brought because they were part of the overall team. The comment about teaching, about how being part of the environment allows the provider to engage in these non-clinical activities, as is what I mentioned before, is important. And interesting, the last, just that very last comment on the slide about the understanding and language. This is something that came through in both what I would say is a technical approach as well as just an interpersonal approach. And by that, I mean that the technical content of one's discipline, being able to communicate what any of us might often have in a very sort of jargony or sometimes unique way, but being able to communicate the technical aspects of our approach to the other providers in a way that they all understood. But then also just general interpersonal communication, things that maybe we might take for granted when we're thinking about providing healthcare, but being able to be a team player, being able to be able to carry on a conversation, whether it be standing at a podium and using slides in front of a formal presentation, or a casual conversation at the water cooler, or being able to function as a team member in those interpersonal aspects is something that a lot of individual CIH providers may not have thought of as being an important part, but it came through again and again that was a facilitator of collaboration, of relationships, and then ultimately of better outcomes across the board. Next slide, please, Beth. Pardon me. And so I'll just begin the discussion and then pass it over to Beth, and then we can sort of circle back and forth. That we found that the providers were, pardon me, they were collaborating. It was not just a parallel processing environment, or where they were sort of isolated or sequestered off in an area on their own, but that it was to different degrees collaboration. And there are many definitions that have been put forth for what that means, but I think anyone who's been in these environments for a long enough time realizes that there's always shades of gray, and that even an individual who is an individual provider who is very well integrated at a facility might have a given week where they're collaborating closely with other professionals day in and day out, and they might have another week where they really don't collaborate that much, but because it wasn't necessary in that given cluster of patient cases or whatever other experiences were going on. So it's not that every day people are sitting around a conference table and planning out their day and checking in 2 or 3 times, but that the collaboration occurs up to the level as necessary as different circumstances arise. And that this collaboration, as we mentioned before, was positive in terms of providing better patient care and patient experience, as well as the individual provider's perception of personal, professional gratification and many times compensation. And the education of students and other providers it was again and again recommended as an important step that the CIH disciplines could take to help position their future folks to better able to fit into these environments with respect to communication and patient care, as well as I mentioned, the interpersonal sort of soft skills of being a team member. And why don't I pass the next slide over to Beth, and then we'll see where we're going.
Thank you, Tony. And I'll speak about conclusions and a few other items. We thought about how could the results of this study be useful, and they can contribute to broadening the scope of interprofessional collaboration, improve clinical outcomes, improve efficiency for healthcare systems, and we hope will be useful to institutions engaged in training, our education, our academic institutions, to help them develop curriculum. And here are some specific examples of how the results of this study could be relevant to training CIH providers, the educational aspect. Students in health disciplines could share classes, cross-training, and that can help develop relationships from the beginning. So it's I think one of the most important factors of interprofessional education is introducing people from different disciplines to each other so that they're learning with each other, from each other, I think, by each other. The students in the health disciplines could receive templates and examples of typical conversations useful for interprofessional collaboration. So here we're starting to get at, well, what are some projects that we might undertake based on what we found in this work and in other work that would actually provide our community with something that they have identified as a need. Students in the health disciplines could shadow providers of different disciplines, that came up in several interviews, and participate in clinic rotations in different disciplines, which would also help facilitate interprofessional collaboration between professions. getting more and more people from different disciplines working together. Here are some specific examples about how results from this work could lead to raising interprofessional collaboration awareness and contribute to broadening the scope of interprofessional collaboration. Templates and handouts could be developed to help providers from CIH disciplines with outreach to educate about what they do. So here's another example of projects that could be undertaken based on needs that have been identified. We could provide written materials or presentation templates or ways that complementary treatments for providers might be undertaken to engage with people in a different format. Here's some more specific just examples to illustrate the points. A chiropractor could work side by side with a massage therapist to offer patients a more optimal pain care experience. A naturopathic doctor could work alongside a conventional medical doctor to treat chronic conditions which may benefit from a holistic approach and require a prescription. Instead of offering conventional pain medication to a patient with chronic pain, a conventional medical doctor could refer a patient to other disciplines, such as acupuncturist, naturopathic, chiropractor, massage therapist, for a more collaborative approach. A direct entry midwifery midwife might receive a referral from an OBGYN from an expectant mother who's interested in a home birth. And it could work the other way around, where a direct entry midwife could also perform a warmer handoff to an OBGYN if complications were to arise during labor. We found a lot of collaboration between direct entry midwives and OBGYNs. They gave us a lot of examples of how they helped each other understand what they do to provide these warmer collaborations. CIH providers could arrange regular interprofessional meetings or case presentations with professionals from different disciplines, including allied health professionals. And again, some of our interviews gave us specific examples of how they were doing this. And we have resources with more of these details. These are just general overviews. We've given numerous presentations. So just from 2015, we've presented at the American Public Health Association, the Integrative Medicine for the Underserved, the International Congress on Integrative Medicine and Health, again at the IM for Us, at the Academy for Integrative Health and Medicine, at Healthier Texas Summit in Austin, and again at APHA. This is probably one of the most exciting outputs of the work, is that you can read about it. So what we didn't cover today, or if you want to get more detail about something, you can actually go to the article. I will be creating a resource document that we will put on the Academic Collaborative for Integrative Health site, which will have more granular input than what we were able to cover today. It will include a link to this article, and also these slides will be available to you so you can look at them at your leisure. Before we conclude, of course, we want to give our acknowledgments to our study participants. Without them, we wouldn't be able to be talking with you today about this information. So it was their willingness to be interviewed and provide information that made this work possible. We also want to acknowledge contributions of our advisory committee, Melissa Denmark, Don Hogue, Marcia Prenguber, Jason Wright, and our project consultant, Patricia Herman. So I'd like to open it up now to Q&A. This is Alyssa Wastra.
Thanks so much. Hi everyone. This is Alyssa. I'm the Executive Director with the ACIH. Thank you, Beth. And all, Anthony and Hannah. What an interesting presentation and a wonderful opportunity to provide sort of this culminating perspective on not only the outcomes of this study, but also, as you noted in one of the last slides, the number of presentations that have been done. since 2015 on this topic. So on that point, I was curious about what that has been like over a span of 3 years to be making these presentations to these various groups on this topic and any kind of feedback that you've gotten. I'm curious about if you've gotten feedback about moving forward on any of the project ideas that you've mentioned throughout the presentation, if there's been sort of any, critical mass around any particular project concept or allied groups that showed interest. Just kind of want to pick your brains a little bit about what the experience of the last 3 years being out in the community, speaking about the topic and the study has been. Thank you.
Thank you, Alyssa. I'll answer that one and then ask Hannah and Tony if they have any feedback to add to that because I've done most of the presenting, and I will say that there has been a lot of interest, a lot of what felt like agreement, like yes, this is how it has been for me too. Eagerness for whatever resources might come forward. I mean, we've been asked. We started out with a poster which summarized everything, and we have been asked repeatedly for the poster itself before the article was published, because people wanted to share this study and the results that we had to share before publication with their communities. As director of working groups at the Academic Collaborative for Integrative Health, I was really excited to see the specifics that the need was expressed for, because we have these working groups who are wanting to serve our communities, looking for specific ways to fill needs. So that is something that we will be bringing to the collaborative working groups to see if there's any smaller project that people want to get together and work on, and also look to our larger communities for resources that may already exist that we can bring to our communities. So Hannah, Tony, do you have anything that from your sharing of the work which may be more informal or more formal to add to that about what response has been?
Sure. I could add something from maybe like two other perspectives. So one, I think, is the perspective of the institutions that themselves, whether it might be group practice settings or the community health centers, or the let's just say the more mainstream side of the coin. There was a lot of agreement there was nothing that I think that I ever encountered where people thought that what our respondents said was very contrary to what they experienced as well, and at some point it was almost implicit that yes, all of this would be great, but a lot of these places have learned this to different degrees through trial and error as they were going along as well, and would like to see that maybe be in some way improved for the future generations. So that, as far as the systems go, I think that was an interesting take. But the feedback that I've sometimes received from individual providers, let's say an individual CIH provider who's not at any institution but maybe has a professional interest or in something like that, I think a lot of times they found it very eye-opening, the concept of not only teaching the others about yourself, but the concept about learning about the others even before you walked in the door, and that I think that was an educational opportunity that exists for these folks. And I think in many cases, maybe I would ask Hannah, as someone who actually did some postgraduate training in an integrated setting, and then went right from that into a major hospital. What would be your perspective from sort of coming through that type of training and then going into a setting that in what way do you think that maybe helped you, Hannah, that would have been harder if you didn't have that?
Right. Thank you for asking that. I was thinking to comment on that because at the end of the day, this study is actually very personally relevant to me because I started the study as a resident working in an interdisciplinary setting, and personally, I felt that I gained so much value from working alongside other medical doctors and other providers working in, I'm a chiropractor, so specifically I'm working in the world of pain, treating pain, and it's invaluable to be next to these providers and see what they're doing, and then being able to apply that to taking care of my patients nowadays, or even when I was still a resident. Working alongside them is very, very different from theoretically understanding what it is that they do. And the other thing, once I started working as a chiropractor after residency, I noticed, and sharing this paper with the people that I was working with here, there was this incredible amount of support and agreement that, yes, we need to work together. The interesting thing is, as I working here, I've had kind of flipping sides of the coin a little bit, having medical residents come through my clinic, and or fellows, or people in other disciplines that are considered mainstream, pharmacy, physical therapy, that sort of thing. And for them, they found it so valuable to learn about what I do as a chiropractor, right? So I think that it's something that is beneficial to both sides, and especially when you start at the beginning of your training, it becomes natural. It becomes natural to work together. It doesn't become, strange or cumbersome. It becomes just part of the way that you would approach care without thinking twice about it.
Alyssa again here, just making a comment. Yeah, I love what you just said, Hannah. I mean, thank you, the three of you, for your comments. I've been taking copious notes here to take into our into ACIH and outwardly. But love what you just said, Hannah, about sort of this opportunity to sort of the experience that you had from a theoretical standpoint to an in real life experience on both sides of the fence, both working side by side with, conventional medical MD residents, and then in your clinic, as you have fellows or residents join you while they're on their path, and sort of having that integrated opportunity to learn from each other early on in your training, and what the opportunity lies ahead around that. Sort of very organic, experience, rather than being imposed later in one's professional path, but the organic nature of learning together. Thank you for that. I'm gonna go back on mute.
Thank you so much for your questions and comments, Alyssa, and thank you, Hannah and Tony, for your responses. Karen, I would love to hear, you had a comment or question, so just unmuted Karen.
Oh, hi, thank you. Yes, and this is just an extension of what the presenters have been talking to us about. But so last night I was in a call with the Chief Medical Officer of the Georgia Hospital Association, who called to discuss a little bit more what the chiropractic clinicians may have to offer for provider networks that he's trying to put together in that area, based upon a presentation that the practice champion, Dr. Tom Stotz, did at Atlanta at the on the 11th of June here, as a recipient of the Pinnacle Practice Award. He was the only chiropractor at this event, and he served on a panel and was talking about what chiropractic does and how one of the reasons they received the award was because they had been recognized. There actually was the first in the nation to be recognized as an NCQA, Patient-Centered Connected Care multi-site, and they received a grant award from the TCPI, the Compass PTN TCPI, to go after, and they did achieve patient-centered medical home recognition under the compliance team, an accrediting body. And so that's what the process that they were presenting on at this conference, where all of these different clinician types were together looking at care collaboration, and they really don't know what chiropractic or what the complementary practices do. And so they were fascinated to understand that the undertaking, which actually we started that process, the NCQA award was in 2016. And so this taking it to the next step really showed that we work very collaboratively with the patient care. And I know Dr. Lisi will be interested in this. We actually used our VA referral patients to establish a risk stratification of the patients for the chiropractic clinicians, and to look at measures about how to reduce utilization rates using our at-risk VA patient referrals. So it can be done, and it's challenging, but it's really exciting, and especially when you have the chief medical officer from a pretty large hospital association reach out and ask, how can we bring in and incorporate more of our complementary healthcare providers.
Thank you so much for sharing that. Anthony, did you have any comments or response to that?
No, it sounds very interesting, and it's great to hear that from that perspective from the people out, boots on the ground where it's actually happening.
And working with the compliance team was one of those real, accrediting bodies are not always boots on the ground kind of people. And so this was a really good experience working with this accrediting body as well. And this was their first experience working with chiropractic as well. So now they have an understanding of the chiropractic clinician and the kind of care chiropractic provides and the care collaboration that is available. Thank you for allowing me to share that.
That's great. Thank you. And that kind of brings me to my next question for the group at large. Please do raise your hand if you have any comments or questions. We have the time and the ability to hear your question verbally. And I was wondering, because there were a few specific ideas that came from our work about what we might do to help enhance interprofessional education and interprofessional collaboration based on the need identified from this study and other work. I'm wondering if there's anybody who's listening right now who has an idea, either something like what we've suggested or anything that you have on your mind that you might want to work on together with us so yeah, let me open it up there and say, please do raise your hand or type something in the question or chat box. I don't see anything. Oh, we do. Okay, great. All right, so this is Vim. I have just unmuted you. Oh, I didn't. There you go. You're unmuted now. Thank you. Vim Osethanagra, and forgive my pronunciation, you're unmuted. Okay. Well, I don't know what's happening because if you raised your hand, I did unmute you. You should be able to speak. Mary Beth, let me unmute you and see if you're able to speak. There you go. Mary Beth, you're unmuted.
Beth.
Hi.
Hi, Mary Beth Mstenda. I'm actually a faculty member at the Maryland University of Integrative Health.
Oh, great.
And I was wondering if people are working on shared medical records across disciplines.
Well, yeah, I can answer that. I think in all of the community health centers, well, I don't want to say all, but from my recollection, the vast majority that was the case. Anytime the provider is part of a system that is classified as delivering care, it would be included on the same medical record. Now, in some of the in this group, I don't recall offhand. Beth, maybe you might have better recollection on the private practice side, how many were actually linked in with shared medical records. I think that would be very less likely or very rare. When a lot of that has to do with the how common EHRs are used in general among the CIH folks, but interoperability among EMRs is a challenge even in mainstream settings or across settings. So from other work, we can say that when the CIH providers are part of hospitals or larger medical facilities, then it's it's the vast majority of the time they're actually using the shared EMR, and whatever documentation is viewable to any provider in the system includes the CIH provider.
Thanks. Yeah, I guess from our perspective, some of the challenges that we encounter are the language between the different CIH approaches, and getting that shared communication on an electronic form can be challenging. I mean, you can have your SOAP notes and things, but I'm thinking more, being a pharmacist, but also being an herbalist, how do we have a shared medication or supplement list that is, going to be incorporating or able to incorporate formulations and herbal medicine and things like that?
Yeah, that's an area that's ripe for the use of technology to help us, I think, even including things like common decision support. I mean, I'm not an herbalist, but I would imagine from a pharmacist's perspective, it might be useful to have some sort of decision support even for the use of herbs that might interact with medications or vice versa. And I think that templates in EHRs that can be developed and then shared. There are a few platforms being put for making application or plug-in development that can be compatible across a number of different EHRs. I think that's the future. And if we could look at tying that in, it would be valuable.
Yeah, be very interested in that. Thank you.
And I can contribute something to that question in that one of the resources that we will be posting on the website gives a summary of the responses to our semi-structured interview questions, and we did ask about electronic health, electronic medical records, and some people told us what they were using and the extent of that, and it seemed like within the system where they had common records there was good collaboration, but if they were outside the system using different records, there was not. So I don't know if that helps. I don't know if that was part of what you were asking, but you will be able to get more information on that in the probably mid-July, or early to mid-July, we'll have those resources up on the website along with this recording. Okay, so we had a question from Anita about the role and contribution of the nutritionist, if there was one. As Hannah mentioned, one of our others in the community health centers category was a nutritionist herbalist, and she contributed equally as all the subjects did to answering the same questions and giving us their perspective. So, but because we promised anonymity, we can't point to exactly what the nutritionist herbalist contributed, but the valued part of the study population. Let's see, does anybody have their hand raised or any other questions? This is a great opportunity. Vim has their hand raised and let me know that they don't have a mic. So Vim, if you want to put something in the chat or a question, I can read it out loud. Since you don't have a mic, I won't unmute you. Any other hands, questions, comments? Well, in the event that we don't get any, I would like to ask Tony and Hannah for any concluding remarks they might have, or just to help wrap this up. And then if we haven't got anything, I'll do the final wrap up.
Sure, I'll just say what a great opportunity it was to work with Beth and the larger association on this, and that I think the message that has been, Beth has been tireless in communicating the results of this project over time, and hopefully the other institutions, academic institutions in the CIH and even in the traditional medical world can benefit from this and training the future providers.
Oh, thank you so much.
And just to add to that, I just wanted to say how this has been a really great opportunity for me, being a young provider, getting into this particular subject has been incredibly relevant to me, and also it's been really wonderful to work alongside Beth and Tony, gaining a lot from them in my experience, and also the relevancy of this particular study has been, like I mentioned earlier, very close to what my experience has been, and I really do hope that we can start to see more collaboration amongst these CIH providers, but also we can start working more, be more mainstream, instead of having those distinctions.
Well, thank you, Hannah. Thank you, Tony. I will say in conclusion, this has been a wonderful team to work with. You can tell we enjoyed our work and we felt that we were productive, and one of the most important overall findings is that these are not our assumptions. We're not saying we think people in the field want to increase understanding and respect between disciplines and want students to be educated about each other's disciplines and how to collaborate. This is what people told us. These are needs that have been identified by people who are doing the work, educators, clinicians. So I'm very excited about having this part of the work done, and now we're just at the beginning of looking at how we might be able to create resources to address needs that have been identified. And some of you have commented in the chat boxes that this is a lot of information to take in, and that you would like to think about how you might be able to contribute, or what other questions or comments you might have, and I welcome that. So thank you. I will be putting this recording up on our website, along with a whole host of related resources that we think could be useful in forwarding interprofessional education and interprofessional collaboration resources related to this study, both from this study and in other work that we think would be relevant. So I thank you all for attending and participating, and in advance for any comments you might have or any piece of it that you might want to work together on. And I say thank you to my co-investigators and colleagues, Dr. Lisi and Dr. Gravrand, for your participation today and for all the study. And please do check our website in a few weeks and keep your eye open for more resources. Thank you so much, and I'll say goodbye now. Thank you.